Position to a D-transposition because it is a bit easier to talk about this item, but I can promise you that I will stick closely to the subtitle. I will start with old stories, and there are many of old stories in this topic. Many of the data and publications I found were published in the last century. In 1958, Heath classified pulmonary vascular disease in a study on 67 patients. Most of them had a VSD. Although the methodology may be challenged of his study, it became now possible to classify and describe the progress of pulmonary vascular disease. And 8 years later, Ferrance published her data concerning the pathological changes which can be observed in patients with transposition. This was an autopsy study as well, and it can be seen very clearly that there are 2 points I would like to mention. The first is, here are the normal cats, and here's the age of the patients, or the deceased patients. And patients with large VSDs have grade 4 plexiform lesions of pulmonary vascular disease. And we see there's high-grade changes also in some patients with intact septum, and we see them early in life. In the first year of life, there are some patients which have grade 3 or grade 4 changes in the pulmonary vessels. That means not only VSD is a risk factor for pulmonary vascular disease. It was Neufeld in 1974 who analyzed the development of pulmonary vascular disease and transposition in accordance if they had an intact septum or a VSD. And here you can clearly be seen that also in patients with intact septum, there are some patients with grade 3 and 4 changes, here these patients, even before the first birthday. Of course, VSD is a risk factor for early development of pulmonary hypertension. There are more patients with higher grade changes in the first year of age. Neufeld concluded that in infants with large VSD, corrective surgery should be performed between ages 4 and 6 months. Why didn't he mention the infants with intact septum? Is the problem of 19% with high-grade changes in the vessels a relevant one, and in 8% of patients not? So concerning the patients with intact septum, he stated that the occurrence of grade 4 changes in even a few such patients, that means with intact septum, indicates the needs for early hemodynamic reassessment of patients with transposition after septostomy or septectomy, probably between 6 and 12 months of age. In my opinion, 2 points should be mentioned in this respect. The first is that the assessment of hemodynamics and transposition is of limited value. The calculation of flow by oximetry are very inexact. That is so because it is difficult to have mixed pulmonary arterial saturation samples if the ductus is open, and it is difficult when there is bronchial circulation that is common in transposition. In the case of bronchial circulation, pulmonary arterial samples are taken proximal to the entry of these collaterals, and these collaterals brings desaturated blood, so that a true mixed pulmonary arterial blood sample cannot be obtained. The measured AV oxygen saturation difference is falsely low, and the calculated blood flow is greater than the true flow. And it can be calculated that if bronchial flow is 10%, the pulmonary blood flow will be overestimated by 40%. The third point is that the AV saturation difference is very small, and that means that a tiny measurement error in this AV saturation difference is translated into a large error in estimating the pulmonary blood flow. We can conclude that pulmonary blood flow is usually overestimated and the pulmonary vascular resistance is underestimated, and that makes it very difficult to have a reassessment in children maybe at 1 year with transposition intact septum to decide operate it or not. Of course, there are recommendations from the 70s where the surgery was not, we was not able to have the neonatal switch operations. 1 year after the Neufeld's publication, Rosengart challenged the recommendations of Neufeld. He provides the hemodynamic data of a boy in whom an atrioseptostomy was done with the age of 2 months, and the switch, the mastered operation, was done with 11 months. And here you see the left ventricular pressures, that translates in the pulmonary arterial pressure. That is, before atrioseptostomy, it was 50 millimeters mercury, before mustard as well. But 1 year after mustard operation, he had a pulmonary arterial hypertension with a pressure of 125 millimeters mercury. Rosengart concluded that this late postoperative complication may occur more frequently than it is recognized. And as we know, Rosengart was right. Here you see the results of a retrospective study of 60 patients after mustard repair, which was operated on with about 14 months. The follow-up was 7 to 24 years, and I mean 15 years, and they screened the patients with echocardiography, and if they found the positive signs of pulmonary hypertension, they do an invasive examination. And you see here the patients they found with pulmonary hypertension. That was a number of 7% of all patients. Some with baffle obstruction, but there are some patients with, they called it idiopathic pulmonary hypertension. And these patients was operated upon, as I said, in the 2nd year of life. When they looked more closely at their data, we see that if the patient was operated, or all patients who had a pulmonary hypertension was operated in the 2nd year of life. So that group of patients which are operated late are the first group which deserve our attention concerning pulmonary hypertension. There's a second group of patients. These are patients who develop chronic RV failure late after atrial baffle repair. They may develop out of proportion pulmonary hypertension, which is characterized by an elevation of pulmonary pressures which cannot be explained by elevated wedge pressures alone. Rose Hesselink presented his data and find out that 25 years after mustard operation, the incidence of pulmonary hypertension is increased up to 18%. And here you see the echo of a patient from our clinic with a severely impaired ventricular function, impaired biventricular function. And that are the invasive data of this patient. He had a wedge pressure of 32 millimeters mercury, but he has also a pulmonary vascular disease with a resistance index of 25 watt units square meter. Because he was a symptomatic patient, we decided not to list him for a heart lung transplantation. So we put a left ventricular assist device, and 1 year after the operation, we did a recath and could demonstrate that the pulmonary vascular resistance dropped down to 4.6 watt units, and that's made him a heart transplant candidate alone. I would not like to go more in detail because tomorrow we will have some talks about right ventricular failure and surgical options in these patients. Although nowadays neonatal arterial switch operation is a treatment of choice, the problem of patients presenting late still exists in developing countries. For these patients, palliative procedures are a possibility to increase transcutaneous saturations here from 60 to nearly 90% and to improve their functional class. The early mortality of palliative baffle repair is about 10%, but late mortality is still a problem. This graph here on the right shows, after excluding the early mortality of here and this of 9%, that's a 15-year survival. It's only 50% in these patients. They had 10 late deaths, 4 due to arrhythmia. The group in London from the Great Ormond Street Hospital presented their data with a similar early mortality, with 2 late deaths, 2 due to arrhythmia, and 5%. Very interesting is that they do this palliative baffle repair in 7 patients without ventricular septal defect. They created this VSD during the operation and were quite successful with this approach. More recent data concerning palliative arterial switch operation came from China, from Lange. It was published 2010. He presented to 21 children with TGA-IVS, and their age of operation were nearly 4 years. The early mortality was comparable, 14%, and the follow-up was 4 years. And they decided to close the ventricular septal defect with a fenestrated patch and follow their patient after that. And if there was a persistent left-to-right shunt and a low right ventricular pressure, that they decided to close the fenestration. That could be done in 4 patients. So they stated that there may be a reversibility of this pulmonary vascular disease in some patients, and that they may profit from a late closure of the defect. Actually, as a long-term daughter of this patient with a closed defect are missing, that is important to keep in mind. Actually, we have a debate if it is possible to perform corrective surgery in patients who are formally judged to be inoperable with the help of the new advanced therapies like bosentan or sildenafil. But I would like to say a word of caution on what demonstrated with the 2 studies coming from Beijing. The first is a study from 2010. There was 86 patients, all late presenters with an age of about 2 years. And what they did is they checked if there is a reversibility of the pulmonary hypertension. And that means if the patient has an increase and has transcutaneous oxygen saturation of 5% or more, they decided that they can operate them, and they did it, and their results was quite surprising. The early mortality was only 7%, the late mortality is only 3%, and the mean PA pressure is 22 millimeters mercury. And the conclusion was that midterm results in TGA-IVS with severe pulmonary hypertension are excellent in the current area. That is hard to believe, and there's a conflicting study 1 year later was 70 patients also with TGA-IVS. The same, it's also from 2004 to 2007, it's the same area. The age of the patients was a bit younger, the follow-up was 2 years, and they had looked at the pulmonary pressure. There are 2 groups with moderate pulmonary hypertension and severe. Severe was defined as more than 50 millimeters mercury. And the results were good in the patients who had no pulmonary hypertension, but the children with high pulmonary pressure of more than 50 millimeters mercury, and that is the same group as here, was quite bad. This was survival of less than 40% after 50, that means after 4 years. It is quite surprising that both studies are published in the same journal, coming from the same hospital with the same authors, but the most recent study does not refer to the first study. So I would like to recommend to read the journals with some skepticism. The next point I would like to mention is that early mustard operation may not preclude pulmonary vascular disease. Wilson published a study 12 years ago with 113 consecutive mustard operation, and he had looked how often he could find an elevated pulmonary vascular disease, and the number is quite high, it is 19%. And there are some patients who are operated on quite early. Here is 4 months, with 5 months, here 4 or 3 months. So what we learned from this study is that there are some patients who are operated on in a very young age, but who also develop pulmonary vascular disease. With neonatal surgical repair, the problem of pulmonary vascular hypertension is virtually non-existent. We think so. However, there is a small subgroup of infants with TGA who show the disease in the neonatal period. In the second part of my talk, I would like to focus on the neonates with pulmonary hypertension. How do they present and how is the outcome? There was a study from Songswang, Toronto, who looks how many patients die before surgery, and this is a number we have already heard today that there are 4% of TGA intact septum neonates who died before surgery. The risk factors were prematurity, pulmonary hypertension, or here said as PPHN, and respiratory distress syndrome, but they have a very special patient group. That is a group, no case was diagnosed prenatally, the prostaglandin was started late, the arterial septostomy was performed late, they do not use nitric oxide, and they had very long transport times. So this data may be biased by these problems. There's a second study, and a more recent study from Groningen, the incidence of pulmonary hypertension in the neonates with intact septum was very high, it was 12%. And the mortality in this group with this high pulmonary pressure was up to 30%. That means 4 of the 14 patients all died preoperatively. How does it come? First, no case was diagnosed prenatally in this study. That may explain a delayed arterial septostomy and a high incidence of pulmonary hypertension. And second, although all patients were treated according to modern standard with inhalative nitric oxide, prostanoids, inotropes, and so on, they considered that patients in which the PPHN did not resolve not eligible for arterial switch operation. So they wait and see how the children died. Of course, the group was not very does not feel very comfortable with this protocol, and they stated in their paper that in a deviation of their standard approach at their hospital, a successful rescue switch operation was performed in one patient 24 hours after the start of the nitric oxide therapy, although the PPHN had not resolved at that time. And that brings up to the question if there is, what should we do with these patients? And there are, I think, only two solutions of this problem, and that is the first is the rescue operation and this small patient group, or there are some reports of successful use of extracorporeal membrane oxygenation in these children. Here's a picture of one. Here is the nitric oxide was started, but this patient had a severe depressed ventricular function, so they started with ECMO, waited for some days, did the switch operation, and this patient needed the ECMO as well after the operation, but it can be weaned successfully. And that may be a solution for these patients presenting with pulmonary hypertension. But the question remains, why does pulmonary hypertension develop so rapidly in transposition? We can speculate that genetic factors are responsible for that, or that characteristic features of intrauterine circulation may lead to pulmonary hypertension in neonates with transposition intact septum. And there's a very interesting study from 1999 that comes from the Toronto group, and they looked retrospectively on 16 fetuses and their outcomes after birth. They compared the prenatal features of the ductus arteriosus and the foramen ovale and could show that in all fetuses the ductus is relatively small. All these patients here are patients with transposition, and that is the normal value for patients with normal anatomy. And the patients with the smallest duct here, this and this, had pulmonary hypertension or died directly after birth. Of the four fetuses with the smallest, as I mentioned, 2 died and 1 had the PHL. So they concluded that it is possible to screen fetuses intrauterine if they may have a problem directly after birth. The hallmarks are a small foramen ovale and a small ductus. And there is a hemodynamic explanation for this problem, and they speculate that in patients with transposition intact septum, the pulmonary hypertension may be related to prenatal alteration of the pulmonary vessels. In the fetus with the TGA that's depicted here, there's a highly oxygenated blood comes through the foramen ovale to the left ventricle and passes through the lungs. So that the mixture, that the oxygen saturation in the left ventricle is very high, in contrast to the normal heart, in which the ductus is perfused by low saturated blood, and that mixes here up with in the left atrium. And it could be shown in animal studies that an increase in oxygen saturation increased pulmonary blood flow and reduced the pressure here in the lungs, elevates the left arterial pressure, and that contributes more to a restriction of the foramen ovale. And the second point is that the ductus in the patient with transposition is smaller than in the normal heart, because only the amount passing through the foramen can pass through the ductus, and this is only 20% of cardiac output compared to 30 to 40% in the normal heart. So these changes and additional the bronchial arterial flow may contribute to alterations in the pulmonary vessels, and they may contribute that pulmonary vascular disease is in a subgroup of patients an intrinsic disease of the TGA intact septum and not a problem of late or early operation. There's further evidence that pulmonary hypertension in transposition intact septum is a characteristic of this heart disease, at least in a subgroup. And that is, if we look at the long-term outcome data from large studies, here in this study from Münster, 312 patients was followed up, and they found out that there was 4 late deaths after 4, 6, 7, and 22 months, and that is a problem of about 1% of children dying late after a switch operation because of pulmonary vascular disease. Debris concluded that in these patients, a primary form of pulmonary hypertension must be suspected. But if you take into account that the incidence of idiopathic pulmonary hypertension in children is as low as 0.5 to 0.7 per million children, the probability of idiopathic pulmonary hypertension in patients with transposition intact septum can be calculated, and that is 1 to 10 billion. To 1 billion, and that means it is statistically extremely unlikely to have 4 patients with this probability of the coincidence of the 2 diseases. That means there is an intrinsic problem with the pulmonary vessels and a subgroup of patients with transposition. Let me conclude. Pulmonary hypertension in transposition is a valid problem in 5 patients groups. The first is adult patients after late baffle repair. The number is about 10%. Adult patients with atrial baffle repair with chronic RV failure are the second group. The number of these patients may increase. The third groups are the late presenters, especially in the developing countries. The fourth are the neonates with pulmonary arterial hypertension. The incidence of 4% is too high in our experience, is at maximum, I would say, 1%. And there is a last group of patients late after neonatal switch operation with pulmonary vascular disease. About 1.5 to 1% will die without specific treatment. And the treatment and prognosis depends on etiology. Mortality is still high without treatment. Thank you for your attention.